is a schematic picture. In this schematic picture, you are going to look at the transfer section from the thorax. This is a naturally adult emitter. Imagine it is the thoracic vertebra, and here is the sternum. I told you the thorax naturally in an adult is going to be flat anteriorly, a little convex anteriorly. But sometimes because of some of the diseases that belong, for example, to the lungs, belong to some of the another disease, such as the tuberculosis, it is possible the form, the shape of the thorax change. We call barrel chest. Barrel chest. The chest is going to get expand and increase very backward. Here you are going to find that here is going to remember you funnel chest. As I explained for you, in funnel chest, the sternum go backward. And the kyphos in the thorax, in the chest, because here or scoliosis, it is going to change this transfer section, form and shape of the thorax. Look at this picture. In this picture, we are going to show you funnel chest. Okay, we have so many grades of the funnel chest. Selected here. It is another form of the funnel chest. And this form, what is the name? Pigeon chest. About the cosmetic it is important. But here it is possible this form of the sternum compress the content of the chest. Now here again we are going to look at the pigeon chest, and this here we have the pigeon chest. Look at the radiography. Posterior of the sternum we have a space, and posterior space we have the heart. It is pigeon chest before surgery, after surgery. It's going to repair. And you know about the joint, I explained for you about the structure of the joint, fibrous joint, and here you are going to look at the synovial joint. We remember the cartilaginous and the capsule and the synovial joint. I explained for you. And here you are going to look at some of the ligament around the posterior end of the rib. Yesterday I explained for you anterior longitudinal ligament, posterior longitudinal ligament. You remember I told you this coastal transverse joint. Laterally it is going to support by lateral coastal transverse, and medially it is going to support by the coastal transverse or medial coastal transverse. Today, here, another ligament I am going to introduce to you that support this coastal transverse joint, and it is visible here. We call it superior coastal transverse. The superior coastal transverse inferiorly connects to the superior border of the neck, and superiorly it is going to connect to the transverse forces of the above vertebra. Three kinds of the coastal transverse ligament I introduced to you. Superior coastal transverse, lateral coastal transverse, medial coastal transverse. What's another name of the medial coastal transverse? Coastal transverse. Now, the medial or coastal transverse, the lateral coastal transverse is going to connect the same number of the rib to the same number of the vertebra. Okay? But the superior coastal transverse is going to connect the ribs to the superior transverse process of the vertebra, not the same number. Okay, this is important. And here we are going to look at the anterior longitudinal ligament, radiate ligament, to superior coastal transverse ligament, and in rear the anterior longitudinal ligament, radial ligament, superior coastal transverse ligament, and in this picture, it is a transverse section. What's the name of this ligament? Lateral coastal transverse. What's the name of this ligament? Medial coastal transverse. What's the name of this ligament? Superior coastal transverse. Here you are going to look at the intervertebral disc, nucleus pulposus and annulus fibrosus. Now we want to explain a little more about the chest. During the inhalation and exhalation, during the breathing, what happens? We can feel during the inhalation, we can feel the volume of the chest is going to increase anteroposteriorly, increase transversely, and increase in height. Look at here. What happened in this inhalation? The air is going inside of the lung. And opposite to inhalation, we have exhalation. Look at here. This form is exhalation. Now, what happened? That the anteroposterior diameter, the transverse diameter, the height of the thoracic cavity increase. About the height, you know what happened? The diaphragm is dome shaped.
Yes.
When it is going to get flat, the height is going to get increased. But what happened about the anteroposterior and transverse diameter? You can imagine here. Here we are going to show you the a handle. Okay, here is a handle that is going to help you to show you that what happened. When this handle is inferiorly normally, we can put this. Do you know what's the name of this? Pump. And this is the handle of this pump. When you want to bring the water out of the stomach, this handle will take upward. After you bring it down, again you should take upward. Now, normally this handle is near the grooves, near the pump. But during the breathing, here, you imagine this spinal, this vertebral column is this palm, and the rib is a handle. What happened here? When normally the vertebral column and the rib and the sternum, the position is here. In the breathing, the anterior end of the rib go upward and forward. So during the breathing, the anterior end of the rib go forward and upward. Before going up, before elevating, this sternum is near to vertebral column. When it is going upward and forward, it is going far from the vertebral column. Such as here, when the handle is down, it is near the palm. When you elevate the handle, it is going far from the palm. Yes? So it is going to remember and show you what happened that anteroposterior diameter in the thorax increase. A little, not a lot. A little increase. So about the anteroposterior diameter, please remember the handle of this palm. And this picture. Now to be able to explain for you what happened that the transverse diameter of the thorax increased, look at your forehead handle. If you look at your forehead handle, normally this forehead and this handle, normally it is down near the forehead. When you want to carry or pick up this object, you take this handle up. When this handle go up, it is going far from the center. But when this handle is down, it is near the center. Okay? Now here, about the rib. When normally the rib is down, look at here when it is going up, the transverse diameter is going to increase. When the rib on normal position, the transverse process is less than they are going to elevate. This elevating are going to increase the transverse diameter of the thoracic cavity. And here is going to show you an abnormality. Cervical ribs. We remember cervical ribs, which often is going to get developed and get blood here and is the transverse process of C7. Now look at here. Sometimes it is possible in all age cervical rib to find the bone. Sometimes only proximal part is the bone and is going to be continued by a fibrous. Okay? In the radiography, the form, the shape of this rib and this rib is different. So we should know that it is possible in some of the person, their rib in all age is going to change to the bone, and sometimes it is possible only some part, a half part we have bone, and continue we have the dense connective tissue. Now here what happens? The subclavian artery normally is passing here. This rib, this cervical rib, is going to compress the subclavian artery. What happens? It is going to compress the lumen. Okay? So, in this patient, you have problem in blood supply of the right upper limb. They are the scalene muscle. We have anterior scalene, medial scalene, and this bone should not be here. But in this patient, we have this bone. And this bone is going to compress the content of passing here. What is the one of the content? The subclavian artery. So the cervical rib is possible making problem for the patient. It is possible making problem for the brachial plexus. And here you are going to look at to the body, you are going to look at to the chest, to the thorax region, the sternum, ribs, costal cartilage, and here is the costal margin, xiphoid process, monobrachial, body, are visible. What's the name of this space? Where's intercostal space? Why the sternal angle is a landmark? Because if I find the sternal angle and go laterally, I will be able to find the second rib. When I find the second rib, I will be able to count it. Just stop there. So if I want to access to second intercostal space, I should use from the sternal angle and find the second rib. Exactly, immediately, in 30 second rib, we have second intercostal space. Okay? Now, we change the picture to be able to explain about the muscle. I'm sure that you know something about the muscle in upper limb. Yes? You know the muscle. Muscle consists of two parts. Some part we call muscle fiber. And the muscle fiber is going to be continued to the tendon. What is the difference between tendon and the muscle fiber? What is the difference? Huh?
Tendon articulates with muscle with bone. But fiber just
Here we have muscle fiber, and this muscle is going to be continued to the tendon. Tendon is continuation of this muscle, but it is a dense connective tissue. Here you are not able find any muscle fiber. This part is part of the muscle. Now about the muscle and the tendon is different, the structure, the physiology from the bigger one. Bigger one also is the dense connective tissue, but the structure, but the role and the function is different. The tendon is continuation of the muscle. Look at here. We are going to look at the anterior wall of the thorax. In anterior wall of the thorax, we have some muscle. You know some muscle. Is it anatomical position?
No.
No. In anatomical position, both upper limbs are in each side of the body, and the palm look forward, and the face is going to look forward. Now, here it is not anatomical position. I want to explain some of the muscle in anterior wall of the thorax. When you come to the dissection room, you remove the skin. You know in histology, skin consists of 3 layers: epidermis, derm, and hypoderm. Epiderm is the external layer. Deep to epiderm we have derm, and deep to derm we have hypoderm. Now, when we remove the skin in anatomy, we remove the epiderm and the derm. After the skin, we are going to show you the superficial fascia. Superficial fascia is a liquid, full of the liquid. In histology, this lipid, this superficial layer is hypoderm. But in anatomy, we call fascia. Inside of the fascia, you can find the vessel, artery, vein, you can find the nerve. Okay? So many nerve, vein, artery are passing through this superficial fascia that in histology you call hypoderm. Now, when you are going to remove the skin here, something happens. In anterior wall of the thorax, you are able to show you the breast, mammary gland. This mammary gland inside of the skin of the back, no. Okay? So in different part of the body, we have something spatial. In anterior wall of the thorax, when we remove the skin, before we move, I should show you the nipple and areole. Nipple and areole. نوک پستان و این حاله دور پستان روی پوست قرار داره. جاهای دیگه که ما دیگه پستان نداریم که. So, in the skin of the anterior wall of the thorax, I should explain for you the breast or mammary gland. You know the breast superficially and able to show you the nipple and the areole. Normally, in anatomy, at the first, we remove the skin very carefully. It takes so many time. And when we come here, we cut here around the areole. So when I remove the skin, in the skin I can find a flum. And this nipple and areole remain over the superficial fascia. Why we do this? Because in the male, spatially, the breast, the mammary gland is so rudimentary. It is not growing more. Okay? Without this landmark, it is possible I make mistake and can't find exactly the position of the breast. To be able to show to the student that in this position we have the breast, we need a landmark. We put the nipple and areole over the superficial fascia and only remove the skin, the part of the epiderm and derm. So when I remove the epiderm and derm, I will be able to show you the superficial fascia. Over the superficial fascia, I have the nipple and areole, and I can explain for you. This part you can find the breast gland. Without this, it is possible I make mistake. I think that here is the breast. But with this landmark, with this sign, It's going to help to me that I can find and show to the student exactly the position of the breast. After I remove the skin exactly and remove the superficial fascia, I will be able to show you the superficial muscles. It is the triangle muscle. What's the name of this muscle? Pectoralis major. Pectoralis major. Each muscle you should remember and get in your mind. Origin and insertion. Origin and insertion. About the pectoralis major, some part of the muscle fiber is going to attach to the clavicle. To which part of the clavicle? Anterior border or posterior border? Anterior border. Medial part of the anterior border or lateral part? Medial. And some of the muscle fiber is going to attach to the sternum. Now, deep to the pectoralis major, some of the muscle fiber, such as this part, attached to the coxal cartilage. This coxal cartilage, the second coxal cartilage to the sixth coxal cartilage, always about the first and the seventh centimeter. So the pectoralis major is going to attach to the clavicle, sternum, and indeed it is going to connect and attach to the coxal cartilage. Which coxal cartilage? The second to the sixth coxal cartilage in all of us. But we have variation for attachment of the pectoralis major to the first coxal cartilage or the seventh coxal cartilage. What's the means of my sentence? Means it is possible, for example, in me, when you dissect, you find that the pectoralis major is going to attach to the first coxal cartilage and the seventh coxal cartilage. It is possible in Ahmad, only you find they have attachment to the seventh coxal cartilage. In Vanya, you find only the first. It is variation, okay? But in all of us, the pectoralis major is going to attach to the second coxal cartilage to the sixth coxal cartilage. Now, in the abdomen, when I remove the skin, when I remove the fascia in the abdomen, I can find on each side 3 thin layers of the muscle. We call external oblique, internal oblique, transverse abdominis. Okay, very thin layer. Now, this muscle in the anterior wall of the abdomen are flat. They are such as this sheet. They are flat. Then I'm going to explain for you the muscle here. This muscle is not flat and it has a bulge and it is going to be continuous tendon. Okay, such as a root. Now, what about this muscle? This muscle, we don't have any bulge. This muscle is such as a sheet. Okay. So where is the tendon? The tendon, the continuation of this muscle, the continuation of this oblique muscle is going to get flat. Means this part, get flat. We call aponeuros. We call aponeuros. So some of the muscles are going to be continued to the tendon. Some of the muscles such as the external oblique, internal oblique, transverse abdominis, because they are flat and broad and thin, they are going to be continued to the aponeuros. Aponeuros is the structure is such as the tendon. But imagine this tendon, you stretch and fold such as this shape. We call aponeuros. Now, about the pectoralis major inferiorly, some of the muscle fiber connect to the aponeuros of the external of the muscle in the anterior wall of the abdomen. So the aponeuros of the muscle in the anterior wall of the abdomen, some muscle fiber of the pectoralis major are going to attach to that. Now they are going to converge the muscle fiber converge laterally. They are going to make a very flat tendon. This tendon is going to attach to the humerus. Which part of the humerus? To the intertubercular sulcus. Do you know the sulcus? You know the sulcus. Sulcus is such as this. Okay, has medial border, lateral border, and here is the floor here. This pectoralis major is going to the intertubercular groove and connect attached to lateral border. Here, it is coming, it is the intertubercular medial border, lateral border. The pectoralis major is going to connect to lateral border of intertubercular groove. Now, here we have a pyramidal fossa. What's the name of this pyramidal fossa? You know. Axillary fossa. Axillary fossa. You know the axillary fossa is pyramid, dome shape. It is the base. In axillary fossa, in the base, the extreme you can find the growing of the hair. What is the content of the axillary fossa? You have artery, vein, nerve, lymphatic node. Now, the nerve make a plexus. The name of this plexus that we can find inside of the axillary fossa we call brachial plexus. You know, you heard about the brachial plexus, yes? Can you draw the brachial plexus?
Yes.
Yes?
Yes.
Okay, tell to me which so these brachial plexus are going to be found inside of the axillary fossa, and we know axillary fossa with the brachial plexus inside of axillary fossa we have a lot of terminal branch. This terminal branch, most of them are going to the upper limb to innervate the muscle here. Never from the brachial plexus we have innervation for the lower limb. Here we have lumbar plexus. Here we have cervical plexus. And here we have brachial plexus. So the terminal branch are going to innervate some of the structure, some of the area near here. Okay? Now, two branches that belong to brachial plexus, and we can call the lateral pectoral and medial pectoral. The lateral pectoral and medial pectoral are responsible to innervate the pectoralis major. So you know the insertion, you know the origin, you know the innervation. What about the function? We can hear this muscle fiber contraction. What happens? When this muscle fiber contract, they become short. They adduct the upper limb to the body, and they are going to help to medial rotation. So adduction, medial rotation, then you are going to put your hand on the barfix and you want to elevate, to lift your body. Okay? This muscle is so active because this muscle has some attachment to the costal cartilage. It is a helper muscle for the breathing. It is not the main muscle, but it is going to help to the breathing. Okay? When they are going to contract, they are going to help to lift, to elevate during the inspection. Okay? Now, around each muscle, you have deep fascia. What is the difference between deep fascia and superficial fascia?
Deep fascia is between muscle fibers. Deep fascia is the epidemic.
Yes. What is the difference in histology? No, histology. The superficial fascia is full of the fat. The deep fascia is empty of the fat. It is a dense connective tissue. I am sure that you have this experience. If you see a meat in your food, a white layer of the sheet you remove and then eat the meat. Okay, about some of the person that they are not vegetarian. They remove the meat. This fascia is deep fascia, free of the fat. Now, It is better, such as your books. You draw a table, write the name, the origin, insertion, function, and innervation. Okay? With this summarize, you can draw a table here and very soon access to a lot of name of the monster and all of the feature, all of the items about this monster. You can carry it in the bus when you are going on, you open that and read one feature of the monster, for example the function. And also, when you draw a table here, it helps to you to get in your mind faster. It is possible sometimes compare some of the functions, some of the innervation be the same. So drawing this table help to you to get in your mind and remember the item that you get quick. Now, I want to bring this fascia that it is going to cover the pectoralis major, and it is near the pectoralis major, and it is free of the fat. We call fascia pectoral. Into pectoralis major, I'm able to show you a small triangle muscle that we can call pectoralis minor. It is triangle. Origin, it is going to attach to the tail, fold, and fifth rib. Sometimes we have ligation. It is possible in some of us, some part of the muscle fiber attached to the second, or some of the muscle fiber attached to the sixth. But normally, in most of the people, we have attachment to the tail, fold, and fifth rib. The muscle fiber convey, make a tendon. This tendon of the pectoralis minor is going to connect to attach to the scapula. Which part of the scapula? Coracoid process. It is a scapula and this coracoid process. Okay? Come and delivery. This muscle is going to attach to coracoid process. Do you know the function of pectoralis minor? Pectoralis minor, the contraction of the muscle, is going to help to the scapula to contract. Of course, it is not the real and the main protector for the scapula, but it is going to help to protect the scapula. What about the innervation? The major pectoral nerve, that it is one of the branch that arises from the brachial plexus, is responsible to innervate this muscle. In dissection room, when we are going to show you the lateral pectoral and medial pectoral, how we can distinguish these two. You find one nerve that arises from the brachial plexus, pierce the pectoralis minor, innervate the pectoralis minor, and go deep to innervate the pectoralis minor. So it is medial pectoral. How can I find it is medial pectoral? Because it is going to pierce in the pectoralis minor and continue, it is going to innervate the pectoralis major. What about the lateral pectoral? It is not going to pierce the pectoralis minor. Okay? And the pectoralis minor is visible here. If you notice, you can find a white sheet here. Yes?
Yes.
I didn't remove this deep fascia. The deep fascia that covers the pectoralis minor we call clavipectoral fascia. Clavipectoral fascia. What's the name of the deep fascia around the pectoralis minor? Pectoral fascia. What's the name of this deep fascia? Clavipectoral. The clavipectoral fascia is going to cover the pectoralis minor, and also it is going to cover another muscle here we call subclavius muscle. Have you ever heard about the subclavius muscle?
Yes.
I'm sure, yes.
Yes.
This subclavius muscle you can here superiorly connect to the subclavius groove in which surface of the clavicle? Inferior. And the inferior end of this muscle is going to connect to the first rib. So subclavius muscle is deep to pectoralis major, It is going to connect the first rib to the clavicle. To which surface of the clavicle? Inferior surface. Which nerve is responsible to innervate? One nerve that comes from the brachial plexus. What's the name of this nerve? Nerve the subclavius muscle. Bring for me the function of the subclavius muscle for the next session. What is the function of subclavius muscle? So look at here, normally the pectoralis major is going to cover the subclavius and pectoralis minor. To be able to show you the subclavius and pectoralis minor, I should remove the pectoralis major. The subclavius muscle and the pectoralis minor, both of them are going to cover what a fascia. What's the name of this fascia? Pectoral. What's the innervation of pectoralis minor? Medial pectoral. What's the function? Protractor. This head is protractor. Do you have a question here? No. Look at here. Here you are going to look at the pectoralis muscle. Do you know the name of this muscle? Deltoid. Between the deltoid and pectoralis major, we have a muscular groove. This is a groove between two adjacent muscles. Here, you are able to find a superficial vein. The name of this superficial vein is cephalic vein. Cephalic vein. What is the difference between superficial vein and deep vein? The deep vein are near the artery and they are not visible. But the superficial vein are this veins. When you are going to injection, we use from this vein. They are near the skin. And the cephalic vein is one of the superficial vein in the upper limb. In upper limb, we are going to explain for you how it is going to form and where it is going to drainage. But here, one of the content, not all of them, one of the content of the deltopectoral groove, we can remember the cephalic vein. And we change the picture. Look at here. In this picture, we remove the skin in half of the breast. Inside of the superficial fascia, only in anterior wall of the thorax. Inside of the superficial fascia, superficial to pectoralis major, inside of the superficial fascia, I am able to show you mammary gland, breast. When I remove the superficial fascia, I also remove the breast. Okay? So inside of the superficial fascia, imagine it is superficial fascia. And inside of the superficial fascia, we have the breast, the structure of the breast. Then we remove the skin, then we remove the superficial fascia to show you the pectoralis major. We remove the breast too. Now we change the picture. Look at here. What's the name of here? Breast. It is nipple, areole, and it is the superficial fascia. It is the pectoralis major. Deep to pectoralis major. What's the name of this? Pectoralis minor. Pectoralis minor. Here you are going to look at two axillary fossa. The artery, the vein, the brachial plexus. Normally, when we want to show you the content of the brachial plexus, we remove the lymphatic node. You know, we have a lot of lymphatic node here. For example, if in some of the person, in one of, for example, a patient, we have the cancer of the breast, to know the breast cancer in the women are so commonly happen. So we should be careful about the cancer of the breast. In the male sex, the prostate cancer is common to happen, to appear. Now, if the mother has cancer of the breast, not only the baby girl, but also the baby boy also should be careful about his health, okay, and follow up. When the mother of the family, for example, has unfortunately has cancer of the prostate, the baby girl also should be careful about the herpes because it is possible, not always. It is the reason should be the gene. Now, when you remove the skin and superficial fascia, you are able to find this muscle. But when you are going about the cancer, I always explain such as this. I explain that imagine we have an apple. At first, some part of the apple we can find, for example, some brown part. The skin change the color. Imagine it is a cancer. Now, then very soon you find this color change, you can remove this color change and the around healthy part of the apple throw over and use from the apple, nothing happens. But if you find late the cancer, this changing of the color is going to increase. If we want to use from the apple, we should have the apple throw over and use from the heart. And if you find the cancer so late, this is not usable. It's through all of them. The cancer is such as this. If you find, for example, the nodule, if you find any change in the breast or some part of the body very soon, nothing happens. Only this small part will grow up. But when it is going to grow up, it is possible it's going to metastasize to the lymphatic node. When the doctor, when the surgeon is going to remove the breast cancer, he or she is going to test the lymphatic node in the axillary fossa to find is axillary fossa lymphatic node metastatic cell of the cancer or not. So in the axillary fossa we have a lot of lymphatic node, and 75% of the lymphatic of breast are going to drain to the axillary lymphatic node. How much remain? 25. So about this 25, we should be careful. It is possible to drain to other part of the body. The cancer cell, it is possible to metastasize to other part of the body. Now, here we are going to look at to the breast. It is over the pectoralis major, inside of the pectoralis major, and here, when you come to dissection room, we are going to show you here. We remove the skin, the superficial fascia, and we are able to show you pectoralis major. What's the name of this muscle? Deltoid. What's the name of this group? Deltoid. Pectoral group. Because this group is inferior to clavicle, it is possible in some of the atlas and some of the texts they call the infraclavicular group. It is another name of the deltopectoral group. What's the content? One of the contents? Cephalic vein. Now I remove the pectoralis major to be able to show you the another muscle. Here. Okay. Here if I increase. Look at here, in this side, we remove the pectoralis major, so I am able to show you pectoralis minor. And here is the subclavius muscle between the clavicle and the first rib. In your exam, it is possible to ask you, all of the following muscle has connection to the first rib except not first costal cartilage. Pectoralis major.
3, 4, 5.
Pectoralis
No.
Pectoralis major. No. Pectoralis major only attached to costal cartilage. Pectoralis minor.
3, 4, 5.
No. Subclavius. Yes. The first. It is one of the questions about the international and about the Iranian, the last semester was about the first thoracic vertebra. I asked them, all of the following muscle has attachment to the first thoracic vertebra except. Later you are going to know which muscle. Now, here, it is a pectoralis minor. Look at the pectoralis minor in upper limb. we are going to show you and explain for you this artery here. What's the name of this artery? Auxiliary artery. Some part of the auxiliary artery is before the pectoralis minor. Some part is passing posterior and some part is after that. Yes? So later when we are going to show you and explain about all of the branch that arise from the auxiliary artery. Some of them arise from the first part, some of them arise from the second part, and some of them arise from third part. First part is before the pectoralis minor, second part is behind after the pectoralis minor, and the third part is after the pectoralis minor. And look at the vein. Again, vein is superficial to the artery. To be able to show you the artery, we should remove the. And here we are going to show you the innervation. One of the nerve that pierces the pectoralis minor and innervate the pectoralis minor, and you continue is going to give the innervate pectoralis minor. What's the name of this nerve? Medial pectoralis. What's the name of this nerve? Lateral pectoral. Lateral pectoral only innervate the pectoralis major, but medial pectoral innervate both the pectoralis major and pectoralis minor. Now another muscle in the thorax. After this muscle we can have some minutes break. Look at here. What's the name of this space? Intercostal space. In each intercostal space we have three thin layers of the muscles. Three thin layers of the muscles. The external intercostal, internal intercostal, innermost intercostal, or intimate intercostal muscle. So we have three layers of the thin muscle that we call intercostal muscle. We call external intercostal muscle. If I remove the external, I will be able to show you the internal intercostal muscle. If I remove the internal, I am able to show you innermost or intimate or intima intercostal muscle. Okay? What's the name of this? External, internal, innermost or intimate. Look at one of the intercostal space. This is the costal groove. Do you remember yesterday, I explained for you about the costal groove. I told you the intercostal neurovascular band are passing from this groove. The intercostal vein, intercostal artery, the intercostal nerve. To be able to get in your mind the position of these three, remember from superior to inferior, the one. We remember you, the vein is upper, after that artery, after that nerve. The position are vein, artery, nerve. They are passing inside of the intercostal groove. When you come to our section groove, all of these three are the same color. Okay? How we can find which of them is artery, which of them is vein, which of them is nerve? With the position. Position helps you. Of course, when you come to the dissection room for the large vessel, the vein, the wall you read in the wall of the histology about the thickness of the wall of the vein. What is the difference between the vein and the artery? In the vein, the wall, the thickness is so less, artery is so thick. So if I cut the transverse section from the artery, the lumen is visible. What about the vein? The lumen is not visible, it's going to close. We know that here we have a lumen. But because the thickness of the wall of the vein is so thin, the lumen is not visible. But in the artery, if I cut, you can find a lumen. And always this lumen is visible. And also about the color in our body, the after the fixation, how we can keep this color in the dissection for long time without any infection. We fix this body. Okay? For the first session, when you go to the dissection room, your teacher is going to explain for you how we fix that help to us to be able to keep this cadaver for long time. Now, when we are going to doing the fix, we use from the artery. For example, the artery in the lower ring, the artery here, or the artery here. Because the liquid about the fixation go inside of the artery, the blood go inside of the vein at end. So the vein become dark, but the artery is a little light, white, in the dissection. Now, we are going to explain for you the intercostal space. In each intercostal space, we have three layers of the muscle: external, internal, innermost intercostal muscle. We are going to look at two costal groove. We know the intercostal neurovascular bundle are passing inside of the costal groove, and the intercostal neurovascular bundle superior vein, inferior to the vein artery, and inferior to the artery, the nerve is visible. According to this picture, these neurovascular intercostal neurovascular bundles are passing between which intercostal muscle? Internal and innermost. It is important. Internal and innermost. They are passing between these two muscles. Now we have the picture. It is the external intercostal muscle. Do you agree?
Yes.
Near the vertebral column, they are visible and they are going to feed each intercostal space. They are coming anteriorly near the two adjacent costal cartilage. This external intercostal muscle, the muscle fiber, disappear and is going to be continued by a membrane, this white sheet. It is continuation of the external intercostal muscle. Because this white sheet between two adjacent costal cartilage near the sternum is continuation of the external intercostal muscle, we can call external intercostal membrane. We can also call anterior intercostal membrane. Why we can call anterior? Because anterior it is visible. Okay? So in each intercostal space, in the left side, in the right side, this external intercostal muscle near the vertebral column are going to be formed and appear. They are coming anteriorly in both sides, near to adjacent intercostal, near to adjacent costal cartilage. The muscle fiber disappear and is going to be continued by a membrane. That the name of this membrane is anterior intercostal membrane or external intercostal membrane. Do you have any question here? Now you answer according to this picture to this question. The muscle fiber, is it correct if I explain for you superiorly connect to inferior border of the superiorly? Inferiorly, it is going to connect to superior border of the inferiorly.
Yes.
Yes. And the muscle fiber are coming anteriorly, forward, downward. Look at here.
Yes.
Such as when you put your hand inside of the pocket of your breast. These muscle fibers are going to remember you that they are coming anteriorly, downward and forward. They are going to remember you the direction of the muscle fiber that belong to the external intercostal muscle. They are coming downward and forward. Okay? So about the external intercostal muscle that head to inhalation, head to inhalation and elevate the ribs because because of the direction of the muscle fiber, you should remember the external intercostal muscle is going to be start to begin near the vertebral column, come anteriorly, near the coastal cartilage, continue to membrane. Okay, what's the name of this membrane? External intercostal membrane or anterior intercostal membrane. Anterior intercostal membrane is near the external. Okay? Now, the muscle fiber come downward and forward. Superiorly connect to inferior border of superior rib, inferiorly connect to superior border of inferior. Something that I'm going to do here, I'm going to explain that. Okay? Such as this room has a floor, has a roof, has a floor. For example, the floor, we have the desk, we have the monitor. We are going to explain something that is visible here. This would help with the picture so many times, always in exam, in operation room. Remember everything about the anatomy of the picture, and you will be able to answer to any question. Now, what about the internal intercostal muscle? What is the difference between external and internal?
The
The direction opposite, right hand there. About the external, it is coming down, forward, it is going down, backward. Okay? So the function is different. It is going to help to lifting, to elevating. What about this? Reversing. It is going to help to exhalation. Okay? Inhalation function, exhalation function. Now about the internal intercostal muscle. Look at the picture. This internal intercostal muscle exactly is going to begin anteriorly. Means if I remove or posterior to this membrane, I am able to show you internal intercostal muscle. Near the sternum, in each side, it is going to start the muscle fiber go downward, backward, go posteriorly, near the vertebral column, change to membrane. What do you think? What's the name of this membrane? Posterior intercostal membrane or internal intercostal membrane. Okay? Know your exam. You are the teacher. You want to ask some question here. You can ask about the position of the posterior, not posterior, internal intercostal membrane, because if I say posterior, you remember. Okay? And I don't want to remember. I want to evaluate your knowledge. If I say the anterior intercostal membrane, you know it is anterior. It is possible I ask you, the anterior intercostal membrane is continuation from which of the following muscle? The internal intercostal membrane or posterior intercostal membrane continuation of internal. Now, about the internal, superior, connect. What is this? Coastal group. Coastal group. The internal intercostal membrane connect to inferior border of the coastal group. Inferior is going to connect to superior border of the lower rib, deep to external intercostal muscle. Now look at the innermost, intimate. You are able to explain. Yes, it is visible. Take care superiorly. Yes. About the internal intercostal muscle, superiorly connect to the inferior border of the superior rib, but lead to the connection of the external intercostal. Inferior rib is going to connect to superior border of the inferior rib, lead to connection of external intercostal. About the superior rib, we can explain another form. It is the coastal cartilage, the coastal group. This group is horizontal, yes, not such as in the part, it is horizontal. This group has the internal border and external or superior border and inferior border. This internal intercostal muscle is going to connect to inferior border of the costal groove, and inferior is going to connect to superior border of the lower limb, lead to connection of external intercostal muscle. Now, look at the inner or innermost. Compare with the internal intercostal muscle. What is the difference? Is it different?
No, same.
No. The direction of the muscle fiber are the same. So the function also is the same. What's the
Exhalation.
Yes, exhalation. And about the intimate or internal intercostal muscle, superiorly, inferiorly. Superior is going to connect to superior border of the costal groove, and inferiorly it is going to connect to medial border of the inferior. You can imagine medial border of the superior rib, it is continuing and connect inferior to medial border of the inferior. Okay? Only thing that you should remember, in all the range of the intercostal space, you are able to find the external intercostal, internal intercostal. But intimate intercostal muscle is not visible anteriorly and posteriorly, only in the middle part, only here, in the last part of each intercostal space, we have intimate intercostal muscle. Anteriorly, they are not visible, posteriorly, they are not visible. We get that? Yes.
What about the origin of the costal?
I told you, it is easy. You can hear the innermost superiorly connect to the internal surface of the superior rib, inferiorly connect to internal surface of the inferior.
All of the legs.
All. And all the range not. Because anterior and posterior we are not able to find anything, only in the 2/5. It's the middle part. Okay? Means imagine here we have the superior rib, inferior rib. About the intimate only we have in the middle intimate. Not posteriorly near here. The vertebral column not anteriorly near the sternum. Here we don't have intimate, only in the middle part. Okay? We get that?
Only the innermost.
Innermost. The internal, external, I explained for you. And the function is such as the internal intercostal muscle, and also you should know another thing that about these three muscles. I remember. Again, we explained this for you. Now look at here. In this picture, you are going to look at the skin, so the facial fascia. Here is the external intercostal, internal intercostal, innermost costal groove. It is the line and covering this groove, coverage of the line. And something else here. You are going to look at one of the intercostal space in one side. You are going to look at three layers of the muscle. What's the name of this membrane? This continuation of each of the intercostal muscle. What's the name of this membrane?
Anterior.
It is continuation of each of the muscles. So be careful about this. And now, before we go for the break, look at here. Sometimes around the line, normally we know each line has a coverage. The coverage of the line we call pleural. Okay? And normally around the line we never has any accumulation of the fluid, but in some of the patients we have accumulation of the fluid, such as the pus, such as the blood. Okay, this accumulation of the fluid is going to compress the line. and make problem for breathing of the patient. You need to pass a needle between the stadial intercostal space, access to this around the lung, and drain this liquid, blood or pus. How can we pass the needle? You should remember, if you want to pass the needle in one of the intercostal space, if you want to pass the needle, you should come far from the inferior border of the superior rib. What do you think? Why?
touch the nerve.
Because we know inferior border of each rib, we have costal groove and no intercostal and intercostal neurovascular bundle are passive here. To be careful and to care of the intercostal nerve, we pass the needle far from the costal groove. But sometimes you want to do the surgery in intercostal space. For example, here you have the injury. You want to do the surgery here. You want to anesthetize the intercostal muscle. You should take and pass the needle near the costal groove to be able to anesthetize this neck. Look at here. If you imagine we have two ribs. Here we have the costal groove, okay, and we know three structures are passing here. Which of them is inferiorly made? Sometimes we want only pass the needle to be able to access inside of the thorax. We should be careful. The needle should pass far from this neurovascular bundle. But sometimes we want to do surgery to this area, and we want to do the suture or something, for example, happening here, we want to do the surgery. So the surgery is going to happen in this area. We need to anesthetize this nerve. So we should inject here, near the costal groove. So your procedure is different. If you want to access inside of the thoracic cavity, you should go far from the costal groove. If you want to do surgery in the superficial and you need to anesthetize the nerve, you can inject near them. Okay, 15 minutes break.